Good afternoon. This is Barbara McLean. Welcome to Wonderful Wednesday. And today's topic is, what does your PA catheter tell you? So we're going to take a quick look at a lot of the information that you can actually get with your PA catheter that can give you a very significant bird's eye view on what's happening to your patient. So, of course, it's the PA catheter and the PA waveform, most commonly referred to as the Swan, which is actually the branded name Swan and Gans for the physicians who developed this based on their experience with sailing. But it's really important for us to appreciate what it's going to tell us. And most importantly, to appreciate, don't expect to be an expert. There's no way in this world today that you can become an expert on the PA catheter, because in general, you won't see more than 20 a year if you see that many. And those who grew up with the PA catheter, like myself, we were doing 1,000, 1,500 PA catheters a year. So it's really hard to become an expert if you're not actually using the information, applying it, and also if you don't make a really strong commitment to hemodynamics. So first, we just start off with this visualization from a bedside monitor, and you can see 2 leads of EKG, arterial blood pressure, and in yellow, the PA pressure. And beneath the PA pressure, you see the central venous pressure. And of course, on this monitor, we're also seeing SAT, end-tidal CO2, respiratory rate, non-invasive blood pressure, but most particular, our focus today is really on the PA pressure. I love talking about CVP, but that won't be our focus today. Our true focus today is the PA catheter. So I want to just review really quickly. It's hard to do when we're not together, but the PA catheter, that long yellow snake, is actually 100 centimeters long. And there are small markers that begin at what we call the distal tip of the catheter, coming back to a small marker. And each small marker is actually marking 10 centimeters until it gets to the thick marker. So I'm hoping that you can see that. The thick marker, which actually demarcates 50 centimeters. And then you move on to thin plus thick. So that would be 60, that's a thin and a thick, all the way to 100 centimeters. Now that's really important, because where your catheter resides in the human body is really going to give you a lot of information about what you're looking at. So you always want to know how much catheter is inside the patient. And there are several types of PA catheters. There's really several types. Here at my hospital, we use primarily the CCO Advanced. That's a continuous cardiac output advanced PA catheter that has the capability for evaluating right heart ejection fraction and right ventricular end diastolic volume and volume index. Most places historically are using a little bit older catheter. They may use the CCO SVO2 catheter, or they may use a basic thermal dilution cardiac output catheter. But in either case, both catheters have multiple lumens. So I just want to make sure we review that PA catheter. And normally there are 4 basic ports. Now I'm going to define a port by the small hub that's at the end of it. So there's 4 channels or 4 lumen that have these hubs. Those 4 hubs, beginning with the blue line, the one I just showed you, the blue line with the white hub, is used to measure CVP or right atrial pressure, and it can be connected and should be always connected to pressure tubing, but you can also use that lumen because that channel ends in the right atria. You can use that lumen for medications and fluids. The distal port, which is the yellow component of the catheter, that distal port actually ends 100 centimeters away at the distal tip of the pulmonary artery catheter. And that distal tip is used to measure pulmonary artery pressure continuously. And you will connect pressure tubing to that. And it will measure wedge pressure or pulmonary arterial occlusion pressure intermittently whenever a balloon is inflated and the catheter sails into an arteriole and the tip of the catheter is only looking forward. This is connected only to pressure tubing never any medication should be given through here. Now, there may be a time that you have an interventional cardiologist or pulmonologist who actually administer a fibrinolytic substance through that distal tip. And that's only if the patient has a PA catheter and they're directing therapy toward, a pulmonary embolism, and they're directing therapy towards that pulmonary embolism. Nurses never hang medication on that yellow lumen because that ends in a very small arteriole with a very low admixture of volume. After that, the other fluid port is the white one, and you can see the white, and it ends in that little hub, and that little hub can be connected to any fluids or medications you want to give. This is called the infusion port, sometimes called the VIP port. It's used for any infusion, any meds, any fluids, whatever you wish to give through there. You can always consistently and constantly give fluid through that line. And finally, the one that ends our ports is a little bit different than the other. It is very short, it is red, and it has a slide bar on it. And that slide bar slides to be closed or slides to be open. And the only thing that ever goes in here is 1.5 cc's of air. And air is the only thing you ever put in there. At the distal tip of the PA catheter, about 0.5 centimeter below the distal tip, there is a balloon. And when you inflate that balloon, the catheter will sail forward into the arteriole, occluding everything from behind it, looking only forward, and ultimately looking forward means reaching the left ventricle. So that port is only used intermittently, and in many institutions, my own included, in general, nurses do not inflate balloons, and we do not read those pressures, wedge pressures. We are going to use a more indirect surrogate, and that's known as the PA diastolic pressure. The other thing is that if you have a basic catheter, you will have one connection known as the thermistor. This actually connects to a small thermometer that resides in the pulmonary artery, and that connects to a cable outside of the patient. But it's an electrical connection. It's a big round hub, and it has prongs on the inside. If you're using an advanced PA catheter, and so advanced, I think we'll use that to include CCO and SVO2, as well as right ventricular ejection fraction catheter. With the advanced catheter, you're going to have two of those white circles that connect to an electrical outlet or an electrical input, and that's going to connect to your cardiac output monitor, and that actually helps you to continuously measure cardiac output. In addition to that, you have this blue card with white tubing. The blue card with the white tubing is called an oximetry card, and that connects as a slide into a handheld, basically a handheld computer device that reads the saturation of hemoglobin that is in the pulmonary artery. Now, why is that important? The only thing I'm really going to talk about today with that is that the blood in the pulmonary artery is mixed venous blood, meaning all the venous blood from every system in the human body mixed together in the right atrium and right ventricle, ejected up into the pulmonary artery. It is a true reflection of utilization and appropriateness of oxygen that's been delivered and consumed at the tissue level. But for today, we're not really going to talk about SVO2. This is step one in our PA catheter. So now we're looking at that basic PA catheter so that you can see it much more succinctly. And again, you see the proximal injectate port. This is really your right atria. It says proximal injectate, but it's the right atrial lumen that ends at around 30 centimeters from the tip. The PA distal, which ends 100 centimeters, or actually doesn't end, is the tip, and it's 100 centimeters away from you. Next to that would be your proximal infusion or RA infusion. That channel also ends at around 28 to 30 centimeters from the distal tip. And then the balloon inflation port. And remember, that has that nice little slide bar that can slide back and forth, allowing you to inflate a balloon sailing the PA catheter into a small vessel and evaluating the pressure in that small vessel to the left atria, to the left ventricle, so an indirect circuit of left ventricular filling. And this just shows you here this beautiful balloon on the distal tip of the PA catheter. So here's that little mark. That's a thin mark. That's a 10 centimeter. And here is your distal tip. And the maximal volume is 1.5 cc's of air. You can't inflate it more than that. You have a specialized syringe that comes with your setup. You could actually go get a 10 cc syringe and attach it, but then you'd rupture the balloon and you'd kill the patient because you'd give them a massive air emboli. So we always use the syringe that is designated for use with that balloon, and any volume less than about 1.25 cc's of air tells you that the catheter is already floated far in. And when you inflate, you don't need much air and you've already occluded. And if you are using a full 1.5 cc's of air, the probability is the catheter is too far out, too far back from the pulmonary vasculature. So that's a way for us to tell about the position of the catheter. Now, in addition to that, we look at the Advanced PA Cat. That's the one I showed you that I have in my office. And those are the two thermistors that connect. That's what allows us to measure continuous cardiac output. The blue card for SVO2, the blue lumen with the white hub, that's going to be connected to pressure tubing. You can give medication through there, but my advice is, if possible, always monitor that pressure. The PA lumen, which is all the way to the distal tip of the catheter, always hook to pressure tubing, never give any meds, never do anything else, always hook to pressure tubing for continuously monitoring the pressure. Next to that is that VIP port, or the proximal infusion. So this, oftentimes the blue one is called proximal injectate. This one is called the proximal infusion. Couldn't they have made it easier than that? No, they didn't. And in all the versions, they didn't make it easier. Proximal injectate is the blue, proximal infusion is the white. And on that white one, we can give all meds, all fluids, whatever we want to give to the patient. And then, of course, that balloon lumen, which has the slide bar, and we actually input gas into that lumen, and that inflates. What you're seeing here is the balloon. Now, that distal port is here at the very distal tip of the PA catheter. The balloon is just below the distal tip. The RA or CVP channel ends right around here, and the VIP port ends right around here. And you see on this advanced catheter, you see that there is a copper filament, and it is that thermal filament which is actually going to pulse heat into the blood, which changes the blood temperature. And so monitoring that temperature either before and after the thermal filament tells us how long it takes for temperature to come back to normal. And that's really the key understanding about measurement of cardiac output with a PA catheter. Okay, so some general rules for hemodynamic measures, and these are pretty straightforward. They're really, really simple. First of all, you just always want to have your patient at a consistent level of elevation. So they don't have to lay flat. They can be at 35, they could be at 45 degrees, but you always want to measure them in that same position. So they've changed their position a lot, but you know where they were when you started in the morning. That's why a lot of times people say they have to lie supine, because they want to maximize the equality of position. So it's really helpful if you can always keep them at a consistent level of elevation when monitoring them. You also level the transducer, and that transducer is what looks at atmospheric pressure and calls it zero. And the place in the human body that's closest to atmospheric pressure, which we call zero, is the right atria. So we actually have defined where we believe the right atria resides, but that's primarily in a supine patient. And that is at the fourth intercostal space in the mid-anterior posterior placement. So mid-chest, fourth or fifth intercostal space. Okay. The other thing that's really important, and I think we've lost this a lot, and it's important for CVP, arterial pressure, PA pressure, ICP, all pressures that you measure that are dynamic, is to print a strip with an EKG on one channel and the pressure that you're measuring on the second channel. So that's a dual channel recording. Make sure that you have set the visualization for your hemodynamic waves in an appropriate scale. And a scale is how the monitor sees the pressure. The bigger the scale, the smaller the view of the pressure becomes. The smaller the scale, it's like a microscope. The smaller the scale, the bigger the waveform looks. We use a small scale for low-level pressures like CVP or PA or ICP. So just always be sure you are using the accurate scale. And the reason you need to do that is because the monitor is going to average the patient's pressures together when it displays the patient's pressure. But you really have to be able to look at waveforms and waveform analysis to have a good understanding of what's happening with your patient who has the PA catheter. Now, I will also say the same thing if you've got CVP. It's really important to do a dual channel recording and for you to evaluate your patient's pressures. Now, when the PA catheter, my job here isn't really to talk about setting up for flotation, although I'm happy to do it. But just to remind you that during insertion, there's some very important aspects here. Your catheter comes out of the box with this nice curve. That curve should actually be pointing towards the foot and towards the patient's left-hand side. So when your doctor starts to put that catheter into his introducer, it shouldn't be turned upwards or it shouldn't be turned towards the right. It needs to be turned what we call cephalad and left lateral so that it will easily float into the right atria. And therefore, once you get to the right atria, you'll inflate the balloon and the catheter will sail from the right atria to the right ventricle to the pulmonary artery and into the occlusion position. I think it really is important, even though you might not be the person floating the catheter, it is really important to appreciate this anatomic structure and the distance. By the time you get to 20 centimeters, so that's 2 small markings, you put the catheter in, you're at 20 centimeters, your catheter tip should have reached the right atrium. And once that catheter tip reaches the right atrium, we inflate the balloon to help float the catheter through the right heart and up into the pulmonary artery. So distance is in rules of 10, okay? So 20 to 25 in the right atria, 30 to 35, you should be in the right ventricle, and at 40 to 45, you should have reached the pulmonary artery. Now, this is not determined by how large your patient is, because this is not about their weight, it's about their thoracic cavity. So typically, by 45 centimeters, your catheter should be in the pulmonary artery. And because the balloon is inflated, the catheter will move forward into the pulmonary occlusion position. That's normally between 45 to 55 centimeters. If it's longer than that, if you're at 70 or you're at 80 or you're at 65 and the doc says, yep, we're in position, things are good, you need to be aware that your catheter has a lot of extra length in there. And there may be extra length because the patient has a big right ventricle, but it could also mean that you've looped the catheter. They had some trouble getting it into position and the catheter can loop and tie itself off. It's really dangerous to have the catheter that far in. Sometimes you can't help it because the patient has a big right ventricle or it was a really difficult insertion. From the time of reaching the right atria to the achievement of the pulmonary capillary wedge position should be less than 15 seconds. So those of us who've used PA catheters and been present when physicians are inserting them, we might say, oh my gosh, I remember one time it was an hour and a half, or another time, it was 40 minutes, or another time it was 5 minutes. 15 seconds is how long it should take for a catheter to reach the pulmonary occlusion pressure. Now, of course, that's measured in healthy people, measured in healthy sheep, measured in healthy pigs, measured in healthy humans. So really important to remember that when a patient is unhealthy and they have plaque and they have valvular dysfunction, they've got a big RV, they've got a big RA, it might take a little more time for you to get your catheter into optimal position. Sometimes you just have to accept that you're not going to get it into the wedge position and be okay with that, because to keep poking the patient and going back and forth and keeping them flat while you're floating a catheter, it's really not the right way to do things. So Really important to remember that you can use PA pressure. You don't necessarily have to get into the wedge position. You can use PA pressure. For most patients, you can use the PA pressure, the diastolic component of the PA pressure, to tell you about the left ventricle. So now this is just a small video from Edwards Life Sciences, and this video is just going to show us the catheter. So a catheter now has reached the right atria. The balloon will be inflated, and we lock it so that we can sail that catheter. So now you're seeing over on your right-hand side, the visualization of right atrial pressure. The catheter is with gentle pushing through the tricuspid valve into the right ventricle, and with gentle pushing through the pulmonic valve into the pulmonary artery, and out into the arteriole, into the wedge position. So now we release the air, and you see that the catheter retracts. And then we inflate again, and the catheter moves forward. So very important to appreciate, with a pulmonary arterial catheter, you will continuously monitor pulmonary artery pressure and intermittently monitor wedge pressure. So this is a recording. This is an old recording. It's been with me a long time. In my office, I have a big box of hemodynamic waves from my history of caring for patients. So you'll see here, catheter is in the right atria, and this is a really big scale here. This is bigger than usual. This is a 60 scale, but this was a known patient who had pulmonary hypertension. So we started with a really large scale. So that makes the CVP will look really, really small. If we were in a smaller scale, the CVP would look bigger and maybe more like what you're used to. Anyway, the catheter enters in the right atria, and inflate the balloon. The catheter, with very gentle guidance and a very gentle push, moves through the tricuspid valve into the right ventricle. And that's where we are here. And we can really understand the uniqueness of the right ventricle, because you have a very rapid slope to the peak, and then a rapid fall, and then you plateau. Rapid slope, rapid fall, and then you plateau. And then the catheter moves through the pulmonic valve, and now we are up into the pulmonary artery. Now, the systolic component of the pulmonary artery is very much like the systolic component of the right ventricle. What's really different is diastole, because our artery is much smaller as a chamber. The diastolic pressure is going to be higher. In the right ventricle, you're looking at a big right ventricular chamber, so diastolic pressure is low. And once you move into the artery, the diastolic pressure is higher. So always important to review basic normal values. Maybe your monitors have something different. It's okay. We're not going to sweat the small stuff. We're just going to remember that right atrial pressure in general is a very low pressure, because remember, the right atria during emptying is basically close to atmospheric pressure. So right atrial pressure, usually 0 to 8, goes up to about 12 if you're on positive pressure breathing. Right ventricular pressure, 15/30 systole, and 0 to 8 diastole, which is what we reflect when we look at right atrial or CVP pressure. In the pulmonary artery, same as the RV systole in general in a healthy person, 15 to 30 PA systole, and remember what's changed is diastole, 6 to 12 millimeters of mercury. And if you're on positive pressure breathing, it might be 8 to 15 millimeters of mercury. And then when we inflate the balloon and the catheter moves forward and occludes the visualization of everything behind, looking only forward, that's your wedge pressure, usually 8 to 12, but it could be a bit higher, could be 10 to 15 if you are on positive pressure breathing. Okay, now special properties of the advanced PA catheter, the Advanced Swan. And the first special property is the one that we're going to be measuring from the distal tip with an infrared light on that distal tip. An infrared light, which you're not going to see because I haven't got it turned on, that communicates with our blue card, and our blue card is into an oximetry cable, and that will be mixed venous saturation. Now, the normal mixed venous saturation, normal, is 60 to 80. And the average is typically around 75%, and you can have a 5 to 10% increase or decrease. That's what's considered significant. So anything that's below 65, anything that's above 85, that's clinically alarming and requires investigation. Now, remember, we're not really going to talk about SVO2 here today. That will be in probably step 2 or step 3 of my series now on the PA catheter, but it is really, really important to remember mixture of all the venous blood that has returned to the right heart is what you're actually evaluating here. You're not evaluating a mixture of arterialized and venous blood. That would be a really bad thing. You're monitoring, you're measuring the mixing of all the venous blood as it returns to the right heart. Okay, another special property of the advanced PA catheter is the right heart ejection fraction. It's a very, very excellent methodology to actually determine if you have right heart failure, because if you have right heart failure, you'll have left heart failure. It's a really good guide as to volume resuscitation or to inotropic resuscitation. So it's quite beneficial to have the advanced catheter with advanced monitoring to tell us about right ventricular ejection fraction, and also to calculate right ventricular end diastolic volume. Now that's the really advanced PA catheter. The other component of the Advanced Swan is the continuous cardiac output measure. And remember, primarily, what you want to remember is that you have this copper filament, and that copper filament kind of transects between the right atria and into the right ventricle, and it pulses, doesn't actually pulse, but it pulses heat into the blood, causing the blood temperature to change. And that blood temperature change is then measured in the pulmonary artery, and how long it takes your blood temperature to get back to normal is what is used in the algorithm of the cardiac output. So in the newer PA catheters, this is done very, very rapidly. It's a very rapid processor with a significant program that you're not changing. The program sequence of heat pulsing, which you don't change, allows you to continuously monitor cardiac, continuous cardiac output. Now, you can be monitoring that with changes every minute, or you can be monitoring that with changes every 20 seconds. That's part of the advanced framework. And that's quite different than historic, where we bolused fluid into the right ventricle, and that time it took for that patient's blood to get back to normal typically took a full minute. So you were actually measuring a cardiac output over a minute's period of time. With this rapid processor, you can measure a change in the stroke volume or the cardiac output every 20 seconds. Now, this is just a visualization, it's pretty straightforward, of the continuous cardiac output PA catheter that is residing, remember, transecting between the right atria and the right ventricle, and heat pulsing. So you can see it goes on, it goes off, it goes on, it goes off, and it does that in relationship to temperature changes. So it's looking at how the temperature changes at the thermistor, and that is then programmed into an algorithm that actually displays your patient's cardiac output. So basically 2 types of PA catheters, one that's continuous and one that is not in terms of cardiac output monitoring. Now, basic concepts. Cardiac output is the amount of blood ejected from the ventricles over a minute's period of time, but stroke volume tells you about amount of blood ejected by the ventricle with each beat. So for me, I'm more interested in stroke volume because that tells me about ventricular efficiency. Cardiac output is heart rate times stroke volume, and in a textbook, the normal would be 4 to 8 liters a minute. But when our patient decreases his stroke volume, so he has less ventricular efficiency or an inadequate amount of volume or an inadequate amount of contractility, stroke volume comes down, compensation is tachycardia. So heart rate goes up. And the problem with that is your cardiac output may look relatively the same. But if your heart rate's gone up and your cardiac output is the same, your stroke volume's gone down. And stroke volume is really what guides us to monitoring and measuring our patients. Okay, so first, this is not an index, this is just stroke volume. We're gonna look at Mr. Smith and Mr. Jones. Okay, Mr. Smith and Mr. Jones, and they're the same age, and they have the same measured cardiac output, but Mr. Smith has a heart rate of 125, and Mr. Jones has a heart rate of 85. So Mr. Smith, when I take his cardiac output, which is in liters, 4.5 liters, I convert that to milliliters, 4,500, and I divide by the heart rate. We now know that his average stroke volume is 36 mils. Okay, Mr. Jones, who has a cardiac output of 4.5 and a heart rate of 85, took his cardiac output in mils, converted it to milliliters, 4,500 divided by 85, that equals a stroke volume of 53. So if we say that our normal stroke volume is 60 to 100, neither one of these patients have a normal stroke volume. But Mr. Jones is much closer to a normal stroke volume, and Mr. Smith has a compensatory tachycardia because his stroke volume is low. Now, I personally find that very informative because that drives me towards therapy. I'm going to give you volume. I'm going to see if your stroke volume improves. Does your heart rate come down? I'm not necessarily looking to see if your cardiac output improves. I want to see your stroke volume go up and your heart rate come down. That's what my goal will be, and that's what the PA catheter lets me look at. Something else that's really important, and you can do this also with a flow track or some other way of looking at cardiac output. But when we talk about systemic vascular resistance or pulmonary vascular resistance, we're actually looking at a calculation of the amount of resistance to ventricular ejection. So ventricular ejection here will be highlighted as cardiac output, okay? And then we look at the beginning of resistance, which is in the artery, all the way to the end of resistance, which is the vein. So it's basically MAP, mean arterial pressure, minus CVP, beginning to end, divided by the cardiac output, and then multiplied times a measurement that converts you into dynes. That's called the dynes factor, and that is 80 dynes. So MAP minus CVP divided by cardiac output times 80. That's what gives you your SVR. Blood pressure is a relationship between cardiac output and vascular tone, but we can't measure vascular tone. So by the way, what we measure is the cardiac is the calculated SVR. So sorry. Okay. And then we talk about our indexed values. So index values are cardiac output indexed to the body surface area. Systemic vascular resistance, index to the body surface area. Stroke volume index is the stroke index, stroke volume index to the body surface area. And EDVI is the end diastolic volume, requires a special advanced catheter index to the body surface area. So why do we need to look at the body surface area? Well, let's go back to Mr. Smith and Mr. Jones. Mr. Smith weighs 60 kgs. Mr. Jones weighs 120. Remember, they have the same cardiac output and they have the same basic height. But Mr. Smith's BSA is 1.8 and Mr. Jones' BSA is 2.4. So now I'm going to take the cardiac output divided by my patient's BSA, okay? So divided by my BSA will give me the cardiac index. So Mr. Smith has a cardiac index of 2.5. Well, normal cardiac index 2.5 to 4. So he's just on the edge of normal. And we know because his heart rate is elevated that he doesn't really have a great stroke volume. Okay. Mr. Jones, who weighs 120 kilograms, has a BSA of 2.4. So we took his cardiac index and we divided that by 1.9. That gave him we divided his cardiac output 4.5 by his BSA, and that gave him his index of 1.9. So now I say, okay, cardiac index 2.5, cardiac index 1.9. Now I'm going to convert that to milliliters divided by heart rate. And Mr. Smith has a heart rate of 36, and 36 divided by 1.8 is a stroke volume index of 20. Normal is 30 to 40, and that's on the low end. And we look over here at Mr. Jones, his SVI, stroke volume index. So we took a stroke volume divided by BSA equals 22. So this is pretty bad. These patients are much, much worse than you thought when you took a look at them. So very, very important for us to appreciate indexing the values means what is the blood flow for the individual patient and their individual size. So after the PA catheter has been placed, you're going to monitor pressures continuously. Hopefully, the CVP right atrial, the PA, and you're going to monitor that continuously. If you have to give your patient fluid or bolus through that right atrial line, turn it off to the monitor, because otherwise you're going to be giving a signal that the patient's pressure is whatever pressure you're exerting to push the fluid in there. It could be 300 or 220. And Epic is going to gather that, your Cerner, your Epic, whatever, is going to gather that data. And it's going to say your CVP is 100, your CVP is 200, et cetera. You don't want that to happen. So you monitor it continuously unless you're giving fluid or a bolus. Then you're going to turn it off to monitor, and you're going to instill your therapy through that right atrial lumen. But your PA lumen, that yellow one, always monitored continuously. And if you're not able to do it continuously or document it or evaluate it continuously, you need to be sure you're documenting it every hour. And then intermittently, and only with approval or an order, the nurse can inflate the balloon that sails the catheter forward into the occlusion position, which means I no longer see the PA pressure. I'm only looking now at the pressure in the pulmonary veins, which will terminate in the left atria, which then fills the left ventricle. So that's really, really important. Now, this is my hospital. This is what I've developed for our monitoring. So this is our pulmonary arterial advanced hemodynamic monitoring. And you can see you have a lot of information that's really basic here, your CCO, stroke volume, cardiac index, et cetera. Down here, there are two pieces of information that are important to me. If you come back for the rest of the modules, you'll hear a lot more about them. One is called cardiac power output, which is about the power of the left heart and the work of the left heart. And the other is PAPI, which is about pulmonary artery pulsatility index, which is about the work of the right heart. So I have put these into our framework because those really are the most current methods for actually looking at ventricular work. But generally, it's only cardiologists who even know what it is or look at it. That is completely calculated by our Epic, so the nurse doesn't have to calculate or figure it out. And then you look below that SpO2, SvO2 hemoglobin, and then all of our oxygenation numbers. So let me just think if this is the right one for what I wanted to look at. I don't think it is, but we're going to see it a little bit later. So, okay, good. Okay. So, oh, yep, it is the right one, but I'm not seeing it here, but in somewhere in the document, the CVP was documented as 180, and that's because they were giving therapy through there, but they forgot to turn it off to the monitor. So Epic was gathering the CVP data as 180, and the nurse was filing it without looking at it. And so it calculated SVR at negative 2,386, in which case you'd have to be an alien who had the hugest vessels in the world with a tiny heart and a tiny blood flow. This is not cohesive with life. Nobody can live with that. So it's a really big error, but it's inscribed into the monitoring. And you'll see here, this was at a later time. Actually, we fixed it that we had a nice normal SVR, but this was abnormal. Okay, so lots of hemodynamic values within advanced PA catheter, and here's the basic list, and it's not even the complete list of all the variables that you can look at. These are the common ones: cardiac output and index, stroke volume index, SvO2, SVR, PVR, right ventricular ejection fraction, etc. You can see here I've highlighted advanced catheters. The advanced catheter information is highlighted or bolded, and this is automatic information that's being gathered by your monitoring capability when you have continuous SvO2 and continuous cardiac output, which means the human factor that can affect the value of what's being read and understood is reduced. It doesn't mean that nurses didn't do a great job. It's just we've reduced the human factor in the science. So it's really important when we're thinking about the PA catheter, because first of all, you would like the PA catheter to reflect what the left heart does. It never did. It never will. The PA catheter is a right heart catheter. It reflects the pulmonary circulation. Now, at the end of the pulmonary circulation, you fill the left ventricle. So we can make some assumptions about the left ventricle based on the PA catheter. But the reason to place a PA catheter is because you need to understand what's happening to the right heart. The right heart, as you know, accepts relatively deoxygenated blood from the system and delivers that into the pulmonary circulation so the blood can release CO2 and uptake oxygen. So that's a really important thing. The pulmonary circulation has very short arteries and veins, a lot more distal arterioles, and they're very distendable. So it's a very low resistance, high compliance area, which means the right heart never really has to work very hard if we have a normal pulmonary circulation. Now, if the pulmonary circulation becomes abnormal, you have positive pressure and it's compressing the vessels, or you have inflammation or alterations in the pulmonary vasculature, such as you would have with pulmonary hypertension, that's going to put an extraordinary burden on the right heart, which was never designed to do much work. It's a very lazy ventricle. It never had to work very hard. And now all of a sudden you're asking it to work harder. And by the way, when we look at how the organs utilize blood flow, your kidneys take 15% of cardiac output. Your brain takes 5%. Your heart takes 5%. There is no organ except for the lungs that actually accepts all the cardiac output, which is part of the reason it has to be a low resistance, a very compliant surface, because all the cardiac output enters into that pulmonary circulation. That's a really important thing. Now, because it's a low resistance circulation, the right ventricle never really has to generate that much pressure to move blood up into that pulmonary circulation. So normally the right ventricle actually generates around 20 to 30 millimeters of mercury pressure to eject blood into the pulmonary circ. The left ventricle is much higher. It's like 7 times higher because it has to overcome the resistance of those long, non-distendable arteries, right? The systemic arteries. So the left heart has to work so much harder to mobilize blood flow. Okay, so again, we go back and we just take a quick look again at the basic swan. So this is a basic swan. And I actually put this in here hoping that we'd have some folks from my institution, because a lot of times we don't use PA catheters and it's always good to review. Now, in my institution, the basic swan only comes from one place, and that's from our cardiac cath lab. Our surgeons use the advanced PA catheter. And if we're floating a PA catheter in the intensive care unit, we always float an advanced PA catheter. The only place that has the basic catheter is down in the cath lab, and this is what our cardiac interventionalist likes. And you'll note here that this requires, because it only has one output for the cardiac output, remember, you need 2 temperature measures for continuous, so there's only one output. This means that you're going to be injecting your patient with cool fluid to change the body temperature and measure intermittent thermal dilution cardiac output. And also, you don't have that blue card, so we don't measure continuous SpO2 with our basic swan. So you might have a basic swan at your hospital. You might have a wide variety of PA catheters, but currently Edwards only makes so what they're doing in the near future, what you'll be able to get is the basic and the advanced CCO-SVO2 right ventricular ejection fraction catheter. Things in between there will no longer be available, but many interventional cardiologists like the basic PA catheter, and so they continue to manufacture that. And Edwards is basically the only company that does it. So now let's just look at the catheter. Once it's being inserted, starts in the right atrium, remember, goes to the right ventricle, up into the pulmonary artery and out into the pulmonary arteriole where it sees occlusion pressure. So I want to just call your attention to the right atrial pressure and the wedge pressure. And what's really important, if you don't understand anything else about PA monitoring, right atrial and wedge pressure, which reflects left atria, these are non-pulsatile, very small dynamic pressure changes, but non-pulsatile. Unlike arterial pressures, so looking at the pulmonary arterial pressure, which is a pulsatile pressure. Now, I can't take the pulse of your PA, but it's a pulsatile pressure. And the thing that makes that pulsatile is the rapid ventricular ejection and the response of the arteries to the blood that has entered them. So right atrial, CVP, wedge, which reflects left atrial, are non-pulsatile pressures. Now they have small waveforms that basically reflect the difference in pressure as the atria contracts, as the valve closes, as the valve bulges into the atria. Those are known as A wave, C wave, and V wave, but they are designed to be non-pulsatile. Doesn't mean that you might not see a pulsatile pressure. You can see a pulsatile pressure in the right atria when you have tricuspid regurgitation, and you can see a pulsatile pressure in the wedge when you have mitral regurgitation, because instead of blood going forward, it's going backwards, and it's doing that with every ventricular contraction, okay? In between there is the right ventricular pressure, which is a combination of arterial and venous or filling. So you see you have this big upstroke of systolic contraction and then a rapid fall down. And remember, I mentioned that before, to a plateau. Big ejection up, rapid fall down to a plateau. So this is empty, empty. This is, I'm sorry, pressure, 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 empty, 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 and starting to fill. Pressure, pressure, pressure. Now that valve has opened, pulmonic valve, empty, 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 and now we start to fill. And that's what that plateau is telling you, filling, right? So this is really important for us to appreciate and understand. So we measure, we have the ability to appreciate and understand that we can evaluate the right atria, we can evaluate the pulmonary artery, and we can indirectly reflect the filling of the left atria and left ventricle with the PA catheter. It's a gorgeous tool. It hasn't been used well. It's being used even less well now because people are very inexperienced, and most of the folks that place it have not been exposed to advanced hemodynamics. So they've just gotten out of med school, and their attending says, you go with the fellow, you're going to float a PA catheter. They don't know what it is. They're not really too sure about it. They're watching a YouTube video, and that is not to demean anybody. We just don't do it enough that we have experts. And that's really, really, really important. That's why we as bedside nurses have to have some expertise. We can guide our physicians in the right way to do it. Tell them when they should be in the right atria. When should they be in the right ventricle? When should they be in the PA? Did they change from a pulsatile pressure to a non-pulsatile pressure? And to guide them as how we're going to use that. So typically you will not actually see RV pressure except when you're floating your PA catheter. When that catheter tip is moving through the RV, you will then see RV pressure, but it should be for less than 5 seconds. And you should never be monitoring RV pressure unless you're using an RV pressure monitoring Swan Ganz or PA catheter. But what we know is that the RV systole is basically the same as PA systole. So RV systole and PA systole in general are the same. So when I look at PA systole, I know that's also RV systole measured at the peak. RV diastole is actually reflected because remember that big drop in the RV pressure? When that RV pressure drops, empties, 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 and drops down, the tricuspid valve opens and the RA is filling the RV. So we're going to see RV diastole in our CVP or in our RA, because remember, we're not monitoring the RV. We're going to take PA systole as RV systole, and we're going to take CVP or RA as RV diastole. So now we've surrounded the right ventricle, systole measured in the pulmonary artery, diastole reflected in the CVP. When you are monitoring RV pressure, you also don't have a dicrotic notch, because the dicrotic notch shows an interruption in the dynamic between the ventricle and the artery. And that dicrotic notch, when that valve closes, you see a tidal wave of pressure change that instills that dicrotic notch. Okay, so when we place our PA catheter and as it's floating, we really want to pay attention to those numbers. If at all possible, you want to record as the catheter is going from right atria, right ventricle into the pulmonary artery and into the occlusion position, so that you can actually evaluate what was the right ventricle doing, what did the PA do, and what did the wedge do. So really, really important. Remember, PA systole is an RV reflector. PA diastole is a reflection. PA diastole is a reflection of how the volume is moved to the left atria and ultimately into the left ventricle. So PA systole reflects the right ventricle ejection. PA diastole reflects left ventricular filling. If I want to know how the right ventricle filled, I'm going to look at CVP, or right atrial pressure. Okay. And that dicrotic notch, remember, is the separation of the two. It indicates pulmonic valve closure, and it's very important in differentiating right ventricular waveforms from pulmonary arterial waves. So this will be my last slide for today. I just want to remind you that the RV, the PA, and the LV have separate and distinct measures. So if you look at RV systole, 15 to 25, and PA systole is quite close to that, but neither one of those is close to LV systole. LV systole is close to aortic systole. So RV and pulmonary artery, very close systoles. LV and aorta, very close systoles. Okay. RV diastole is much lower than PA diastole. LV diastole is a bit higher. And that's why your PA diastole is higher, because the pulmonary artery is go into the pulmonary veins, fills the left atria, fills the left ventricle. So in a backwards direction, what we'll say is LV diastole is low, PA diastole is higher than LV diastole, and RV diastole is significantly lower than PA diastole. That's what makes blood move from RV to PA, from PA to PV, pulmonary vein, from PV to left atria, from left atria to left ventricle. It's a beautiful deal. It's a beautiful deal. And just remember, the RV and the PA have similar systoles, dissimilar diastoles. The LV and the aorta have similar systoles, dissimilar diastoles. And that's because ventricles are great big chambers, and they're limited, whereas the arteries are much tighter chambers with a much smaller lumen, and therefore a higher diastole. Pulmonary vascular resistance, normally that's the calculation from mean pressure in the artery. So that would be the PA artery to the end of the pulmonary circulation. That would be the wedge. So PA mean minus wedge divided by cardiac output times 80. Nobody cares anymore if you know those formulas, because all your equipment calculates this, but it's based on being sure that the information you're feeding your device is correct. Normal vascular resistance in the pulmonary bed, 150 to 250. But systemic vascular resistance, 900 to 1400. Remember, the left heart has to move blood further against more resistance, and the right ventricle is weak. It's lazy. It doesn't work hard because it moves against very low resistance. But both ventricular chambers are important. And the use of the PA catheter can tell me about filling of the RV, ejection from the RV, and ultimately filling of the LV. But ejection from the LV must be measured in the systemic arteries. So if you're critically ill and I've been asked to consult on you, and I believe that you might have some right heart dysfunction, you will get both a PA catheter, and I will also monitor cardiac output and stroke volume from your systemic artery, because what I receive from the PA catheter is about the right heart, except for the filling pressure, which would call the wedge pressure of the PA diastole. What I evaluate from my left ventricle is what I'm going to see in the systemic artery, and they are not the same. Sometimes they're the same when somebody's really healthy, but why do they have a PA catheter if they're really healthy? Patients who are critically ill have a dissimilarity between right heart measures and left heart measures. So that's step one in what the PA catheter can tell you. And I'm going to urge you to join me next Wednesday for step 2, and following that will be step 3. So what we'll cover is all the different waveform analysis, and we'll cover SpO2, and what it is we can do to improve our patients' outcomes and their therapeutic interventions while being the beneficiary of a PA catheter and perhaps an arterial-based cardiac output. Thank you very much for coming today. I so appreciate it, and I'm very happy to see you.